Hey YouTube, this is Nurse Jessica. This is my channel. I've actually changed the name. It is now Jessica Lovato RN, RN, just to make it a little bit easier for people to find me. But anyways, welcome to this week's video. This week I'm gonna talk about me and my experience a little bit. I've been in the ICU about 5 months now. It's been challenging. I've had a lot of growth, very informative, very eye-opening, very different than what I was doing before. So that's what I want to talk about this week, is my experience in the ICU so far. Okay, so why don't we start with the positive? I want to start with the things that I'm really loving about the ICU. So the first thing for me is the teamwork. The teamwork is on point in the ICU. I mean, you get an admit and you've got like 3 or 4 nurses there getting the patient into the bed, hooking them up to the monitor, swabbing their nose for MRSA, like everything, helping you assess their skin. So that is great, and something I'm not used to being from med-surg, because in med-surg everyone has so many patients, everyone's just treading water. It's like, sorry girl, ain't got time to help you. Good luck. My thoughts will be with you. That's the first thing that I really like about the ICU. The second thing is the resources. Like the storage room. The storage room's totally stocked with everything you could possibly need. I have yet to have to go on a crazy hunt to find, I don't know, a Foley or ostomy bag or NG tube. It's all been right there, which that's really great. Also the Pyxis, or we have an AccuDose, that's always really well stocked as well. And so far, every time that I've had to request a med from the pharmacy, something that they have to make, it's gotten to me really fast. So I do not take those things for granted, because I've had the opposite happen. Okay, the next thing is, this one's really related to learning. I identify as a forever student. I love to learn. And the ICU is a great place to do that. I feel like I've really gotten to understand some disease process a lot more in depth, because I have the time to focus on that patient, the time to look things up, and also with pharmacology as well, the time to look up medications. Some people are on a lot of medications, so you have to take the time to see what medications can go together in an IV line, what needs a central line, what needs a peripheral, etc. So that has been really great and something that I personally enjoy. The next thing is my nursing skills. You really get to practice a lot of nursing skills in the ICU. So if you're not so great at NG tubes, OG tubes, Foleys, IVs, you're gonna get to practice all of that there. So yeah, working with PEG tubes, chest tubes, everything you learn in nursing school, that's gonna happen. So that's good, because the more you practice, you're only really gonna learn that with practice. And every human body is a little bit different, so you're gonna learn certain tips or what works for certain body types. So that is really great as well. The last thing I want to talk about is getting comfortable in emergency situations. So, you know, in a lot of other areas of the hospital, your patient shouldn't get to the point where they're going to code, and except for very special circumstances, maybe like a pulmonary embolism or something. It's very rare that your patient goes from being just fine to not fine at all. But in the ICU, obviously, those are the sickest patients in the hospital. So they're already kind of teetering on the edge there. So you have to be very observant, which I was well, I'm not gonna lie, I'm still nervous every time I go into work, but a little bit less now than I was at first. So the chances that you're gonna run into a code situation are higher. And I feel a lot more comfortable in those situations now, not because I've done, you know, when you're in a code, there's a person that's recording, there's a person that's pushing meds, there's a person that's making sure you have a line, there's a person that's handing stuff out of the cart, person that's doing compressions. I haven't had the chance to do every single one of those positions. but I've done quite a few of them, which helps me to feel comfortable. But I think what makes me feel the most comfortable is knowing that I'm not alone. That's back to number one, the teamwork, and that people are going to be helping me, directing me. And my biggest job as a primary nurse is really knowing that patient, their history, why they're there, and what is what has changed in the past few hours, 24 hours, to get them to this point. So yeah, if those things sound exciting to you, or if those are goals that you have in nursing, then I would highly recommend considering doing critical care at some point. So now let's talk about dislikes. I mean, every job has pluses and minuses, and my pluses might be your minuses, my minuses might be your pluses. But for me, there are certain things that I think are just hard for me to cope with mentally. One of those things in the ICU is you get people leaving and coming back a lot towards their end of life if they have chronic diseases. And sometimes that can be frustrating because you might see them at a point where they could be leaving the hospital or going up to med-surg and then discharged. And if they would make the life changes, if they would take their medications appropriately, like there's a chance that they could have another 10, 15, 20 years to their life. But because they've grown accustomed to a certain way of living, and they, for whatever reason, because we don't want to judge people because we don't understand everyone's specific life experience, but for whatever reason, they don't have the motivation to make those changes. You see them go and come back and go and come back, and every time they're a little bit worse, which brings me to my next point. You see people not make it out of the ICU ever. And that's hard, and it's hard realizing, wow, this person is probably going to die here. Which is my last point, is that you see patients deteriorate to the point of death in the ICU. Probably, I would venture to say, more commonly than any other part of the hospital. And that can be hard. And so, I wanted to also talk about some challenges and some things that have helped me grow a lot. And talking about death is one of those. And oftentimes you're not talking to the patient because at that point they're not responsive, or maybe they're on a ventilator or life support, but you do have to talk to the family. And as a nurse, I wouldn't necessarily say it's appropriate for us to tell them that your loved one they have this chance of dying here. I'd say that's more a topic for the providers, the doctors, but I do think it's part of our jobs to educate and help the family understand exactly what's happening to their family member. Because I've seen this happen where a patient's on, a bunch of vasopressors, they're on a ventilator. Like, if those things weren't running and connected to them, they would be dead. But the nurse just says, when the patient asks, how are they doing? The nurse just says, their vitals look good right now. And that might be true. But when you just say that gives the family member false hope. What you need to do is say, their vitals are stable right now, but this is what this medication's doing. This is what this medication's doing. This is what this machine is doing. And what that means is that their body isn't doing any of that for themselves. And I'm not saying that there isn't a possibility that we might be able to wean them off of these things and their body might start doing that for themselves again. But you have to understand, if they weren't attached to all these things right now, their body would not function. And by not function, I mean it would die. And I know that is a really hard thing to say to people. And if you're just not there yet, I think it's totally okay to just make the observation that, well, they're stable for now, so let's just take things one day at a time and let the provider talk about it. But for me personally, I think the sooner the family can understand, the sooner they can start to cope and to grieve. And I think that way you're not just helping the patient, but you're helping the family. Because sometimes when family members don't understand those things, they end up keeping their loved ones on life support for what, in my opinion, is too long. And that's not taking care of the patient, because we don't want to prolong suffering. So I think I got a little bit deeper into that than I had intended. But those are just some tips that I have for talking about the disease process and death and dying, which, if you work in a critical care area, is part of your job. But let's move on to a little bit lighter things. Other things that I've had to work on are prioritizing. Prioritization is different in this setting because as an ICU nurse, we tend to be a little OCD. That's just how it works. And so you get there, you want to do your chart checks, and then your assessment, and then this, and then this. But it doesn't always work that way, because sometimes you come into a really dire situation and you're going to be stuck in that room for a while, and that is your priority. And so you have to learn to use your resources to get everything else done outside of that priority. It's okay to ask someone if they have a minute, can you go check on my other patient and make sure they're okay? Or, hey, I have a bag of fluids hung up behind my other bag, can you just switch those for me, please? Or could you please give my other patient pain medication or answer that call light? I can't leave here right now. That's okay, because you're going to be doing that for them in the future, and that's part of teamwork. I think I've also gotten better at calling doctors. Calling doctors, I think, is one of my least favorite things about nursing, especially at night, because it's not fun to call someone at 3 a.m, but that's part of their job and it's part of your job, and the patient comes first. So now I have everything in front of me. I write down every topic I want to touch on. I have my computer open. That way I can give them a quick answer if they need to know what was that specific lab, or when was the last time they got this, are they allergic to this? Because the last thing you want to be doing at 3 a.m. when you're calling a very tired doctor is saying, oh, hold on, wait for me to log into my computer, or I don't know. That is bad for both of you. And then the last thing I want to talk about is I think my report skills and my assessment skills have gotten better. Report is a lot more thorough in the ICU, but my advice is to walk through the report sheet. So give their diagnosis, when they got here, code status, history, just walk through that report sheet. And then give anything new that has happened on this shift. We DC'd this. Their temp was this last night. I gave this. This is their plan for today. Just wait till the end to do that. Give the basics, because that nurse might not know anything about that patient, and you're putting the cart before the horse, so to speak, if you're telling them they were nauseous last night and I gave them this before you even tell them why they're there. And then the last thing is my assessment skills have gotten way better. You, like I said, you have 1 to 2 patients, maybe 3 under certain circumstances, and you really work on your head-to-toe assessment, all of it. Neuro, integument, cardiac, pulmonary, digestive, all of it. You're looking head to toe, and you have the time to do that because you only have 1, 2, maybe 3 patients. And that's great, because also when you're in the ICU, you really get to hear, oh, that's what rails sounds like. Oh, that's what a murmur sounds like, because your patients are sicker. So they have those things and they're a little more audible or obvious. That's what pitting edema looks like. Whereas on other units, you might be like, is that pitting edema? Because your patients aren't as sick. So they might have a little bit, but not a lot. So yeah, you really get to dive into all these things. So that is pretty much all that I have. My last bit of advice is just to really dig deep in for yourself as a nurse and figure out how you cope, because you're going to be facing some really difficult situations, some very stressful situations, some very sad situations. So you need to know what you need to do to cope. For me, that starts with my thoughts, and I think this is what I think. And this may or may not work for you, but I think everyone has sadness that they're going to have in their life. And when someone's going through something sad, I feel for them. I always offer prayers, because I have yet to have someone say no, even if they don't feel very religious at those moments. I think it's always helpful to have some support spiritually. But I think everyone has their sadness, and right now it's time for that family to have their sadness. Tomorrow it could be my time, but I can't take on the sadness of the world because I would just crumble, and that goes for everyone. So I think I can support them as much as I can in their time of sadness and respect that and know that my time will come eventually, and that's when I can feel my sadness. And I guess that just helps me not to take on more than I can handle, because we can all only handle so much, right? Okay, so this video got a little more intense than I had originally intended, but it was honest and real, and it is what I've experienced so far. So if you have any questions, if you've had any different experiences, if you just whatever, I'm here for you guys. Like I said, I am Jessica Lovato RN. That's my new channel name. Like, subscribe, comment below if this is helping you at all. Give me suggestions. Thanks for listening. Thanks for watching, and we'll be with you next week. All right, have a healthy week, guys.